MTF, or male to female gender affirming surgery, is typically involving breast augmentation with either saline or silicone implants, potentially with fat grafting in conjunction. Typically, these patients' breast development halts at Tanner stage 2 or 3, and so they need breast augmentation to achieve the volume that they desire. The age requirements for male to female gender affirming breast augmentation is 19 years old currently. We were happy to see consultations at a younger age. Typically, the FDA recommends breast augmentation closer to breast development, which is around 21, 22. And so typically, I'm seeing patients around this age. The WPATH, or the World Professional Association for Transgendered Health, does have guidelines for gender affirming surgery. Things we look for are social transition, so living as the desired gender for at least a year, that comorbidities such as depression, anxiety are well managed, that the patient has a good support system. Hormone therapy, I think, is beneficial. And so typically we would want to see patients on estrogen therapy for a year, and that is due to the breast development. So this gives more soft tissue coverage for the implant, potentially may make patients a candidate for prepectoral or subglandular, subfascial augmentation. And it develops the breast in a way that it expands the soft tissue envelope that makes them a better overall candidate for breast augmentation. So typically I'm seeing patients who have been on estrogen for over a year, sometimes even many years. Typically, breast development will increase those first 3 years. So after 3 years of being on estrogen, you've likely gained the breast tissue that you're going to have. And so that is typically when I see patients. So they might develop like an A or B cup, but it's typically not the volume that they are seeking. Patients also tend to have a constricted lower pole. And so some additional work needs to be done with augmentation to obtain a proper kind of breast mound or roundness. The nipple areolar complex to the inframammary fold is the lower pole. And so typically in, say, cis female patients, this is elongated with breast development. In transgender female patients, that breast development halts in Tanner's stage 2 or 3. And so it tends to be a little bit constricted or maybe even tuberous, where the nipple areolar complex can even be a little herniated, but that distance from the nipple to fold tends to be shorter. And so that lower pole is constricted. So that lower pole typically needs to be lowered. Even the caps will be scored or radial scoring to allow that lower pole to expand so that it can kind of accept a breast implant. And so that nipple areolar complex will land at the most projected part of the breast mound. I've done breast augmentation in transgender patients, 300 cc up to into the 600 cc, and that's above and below the muscle. So I think that discussion needs to be had with the patient. So certainly you can probably go larger when you're going above the muscle so that you're not constricted. That requires mesh to support the implant. But typically, transgender patients have a wider breast diameter, and so larger volumes are typically needed because the diameter of the implant needs to closely match their native breast width. So you're already looking typically into higher volumes. I would say on average, I'm into the 400, maybe low 500 range in order to gain that projection, that cleavage, and that upper pull volume that the patients are desiring. I size patients at their consultation appointment. I discuss where they're at, how much breast development that they have, and then their desired goals. And so, if patients are, typically telling me that they say want to go up, 3 cup sizes, typically about 150 cc's in an implant is a cup size. And so that gives me an indication that we're probably looking into that low to mid 400 range. I have patients try on sizers here in the office, and that's just over top of their native breasts in a sports bra, basically. And so they get a better sense of contour, volume, and they give me a better sense of what size implant they feel fits their frame and what meets their desired goals. And so I never commit to an implant going into the operating room. It's hard to know how the implant is going to fit into the pocket. And so some of those things need to be decided intraoperatively. So I size patients around that volume goal that they chose at their consultation. And I'm able to put in different sizes in the operating room to get a better sense of what cosmetically looks most appropriate. The technique that I perform the most is an inframammary fold approach. Part of the reason is because, like I said, there's a constricted lower pole. And so that inframammary fold needs to typically be lowered so that when you get the implant in place, the nipple areolar complex is landing at the most projected part of that breast mound. So in order to put in larger implant, that lower pole needs to be stretched. And so I measure where that new inframammary fold will be, and that's where I make my incision. That way I have access to the lower pole to open that up to do radial scoring, which is just releasing the breast capsule to allow the lower breast pole to round out. And then the discussion is, are we going above or below the muscle? So subfascial, subglandular, or submuscular. And so that's just a discussion with the patient. There's certainly pros and cons of each technique, but I would say 99% of the time I'm going through a inframammary approach. Based on the goal size and implants selected, we figure out where the new inframammary fold should be so that once we get the implant in place, that nipple areolar complex is at the most projected part of the breast. Preoperatively, we do the measurements. And so, we're looking at breast width. So their native breast width or diameter is going to closely match the diameter of the implant we're selecting. And so when you think about the breast diameter, that nipple to fold distance in order to have the nipple areolar complex at the most projected part is that radius. That said, it needs to account for the curvature of the implant. And so that you need to take into account the projection of the implant you're selecting. Typically, this is moderate plus, or even high profile implants. So we're going to be adding, at least probably 2 centimeters to that distance from nipple to fold when we're deciding where that new inframammary fold will be located, and thus where the incision is going to be made. Before and after photos can be seen certainly on our website as long as patients have given us consent to use them in that fashion. Typically, once patients follow up at their final post-op appointment where we take photos, they can check off if they're open or giving us consent to use their photos in different manners. Sometimes that can be social media, that can be the website, that can be just at consultations. And so you can see some of the before and afters on our website. But during the consultation process, there are many more photos that we have available for patients to see before and afters of what these techniques look like or what to expect through this transition. Recovery is typically low activity for those first few weeks. All the sutures are under the skin and dissolvable. I don't use drains with this procedure. And I have patients wear a bra for probably 6 to 8 weeks, day and night. It does take about 3 months to form a capsule. And so we do want to keep those implants supported during that process. But typically, patients don't require much of any narcotic medication. I think they're pleasantly surprised in the ease of recovery. But right after surgery, I do tell patients it's going to feel like there are 2 rocks on the chest due to swelling and inflammation. And it can take many months for all of that swelling inflammation to settle and for the breast to become more mobile and drop into the pocket and kind of act more like breasts. But as far as activity, if everything looks okay at 2 weeks, I'm okay with patients starting to slowly increase their level of activity over the course of the next few weeks so that hopefully patients are back to their baseline activity somewhere between 4 to 6 weeks after surgery. We see patients post-op day 1 or 2. That is because if there's going to be a complication, 90% of the time that's going to be in the first 24 to 48 hours. The one thing we are always concerned of is if something were to start bleeding or a hematoma. While that doesn't happen very often, we certainly want to make sure that there's no concerns that it has happened. And so we see patients post-op day 1 or 2. I typically see patients at around 2 weeks after surgery, as well as 6 weeks after surgery. And then we wait for all the swelling inflammation to go away. Somewhere between 3 to 4 months after surgery is when we take final photos. It's a layered closure. Those sutures are going to dissolve over the course of many months, but the incision itself, it takes 3 weeks for a watertight closure. And so I tell patients to not introduce any products for those first 3 weeks. If they want to start scar products, we can do so at 3 weeks after surgery. I don't have patients submerge as to not introduce any bacteria from stagnant waters for that first month after surgery. But ultimately, in an adult, it takes 9 to 12 months to fully mature a scar. And so it's going to be pink and raised for many months until it starts to lighten and flatten. That is a continued conversation that I have with patients and products, and certainly using sunscreens over incisions as well to not allow the UV to disrupt that process of remodeling and keep the incision pink. 9 to 12 months is the short answer. I would say final results are typically between 3 to 4 months. It's when the capsule's been formed, the implant is dropped into the pocket, the swelling and inflammation have resolved. and the breast is more mobile and acting like a breast. That's when I tell patients that it's okay for them to get properly fitted for new garments. So it's typically around 3 to 4 months is when we see patients with their final results and take final photos. We certainly have the discussion with our patients preoperatively at the consultation about their desire for whether they want saline or silicone. Saline implants can be a lifetime model as long as they don't rupture. If they rupture, obviously the body reabsorbs that fluid, the breast deflates, and so patients will typically want to be seen and have that replaced. Silicone implants are a little bit different. The FDA does recommend exchanging them probably about every 12 to 15 years. Just with the wear and tear on the shell, the rupture rates with silicone implants is about 1% per year. So beyond 15 years, that increase risk goes up kind of more exponentially. And so typically we will want to exchange these before 15 years. Typically, the FDA recommends that we start to get breast ultrasounds around 7 to 8 years after placement just to look at the integrity of the shell of the implant. If we have concerns with either ultrasound or just on examination, we may get a breast MRI to confirm if they are ruptured, as this may push us into replacement sooner. Patients with gender dysphoria, so patients who are transitioning male to female, insurance does cover this, so we can certainly submit this to insurance for pre-authorization. To schedule a consultation with us, you can always visit our website, portlandplasticsurgerygroup.com, where you can write in and our leads will contact you. You can call us directly at our office as well to schedule a consultation, and that's 503-292-9200. Regardless, through the website or phone call, we can get you scheduled and get you in our office as soon as possible to see us.